audience and also to people who might be tuning in over the internet. And if there are any questions, we ask that you come to us, interrupt us, ask anything you want, any questions that you like about lung cancer or anything else for that matter. Dallas Cowboys having a bit of a rough year, but not totally out of the playoff race. We want to talk about that. States, you can ask about those things as well. I'll introduce KARTIK Konduri just by name and let him tell you a bit about himself and what he does.
Thank you, David, and thanks for Bonnie and Ario's fantastic support group for having us over here. I am a medical oncologist with the primary intent of work in research in thoracic oncology. I am co-medical director for the thoracic oncology Center of Excellence here at Baylor, and I work closely with David where we try to help take care of our patients in a sort of a singular collegial way to get a multidisciplinary approach for our lung cancer patients. And thank you for being here, and thank you for having me.
Stacy.
Hi, I'm Stacy Webb. I'm the program manager for Nurse Navigation here at Baylor, and I am part of the multidisciplinary care team helping patients get through their cancer journey. I'm also a registered nurse by trade and have been a nurse for about 20 years.
My name is David Mason. I'm the Chief of Thoracic Surgery for the Baylor University Medical Center. I'm a thoracic surgeon, and most of what I do is related to the treatment of thoracic cancers, most of which is lung cancer, esophageal cancer as well, but mainly lung cancer. So that's how I spend the majority of my life taking care of patients with lung cancer surgically and in conjunction with Dr. Konduri and a team of people who take care of them. I'd like to go around the room. Anyone like to introduce themselves? We have some food. You can sit down and answer that. Questions? Go ahead.
My name's Barney Rickman. I was diagnosed with lung cancer in May of 2016. I was caught very early through surgery. I am dealing with follow-up care, and I will be 18 months cancer-free, hopefully.
Anyone else want to introduce themselves?
I'm Robin Lewis, and I'm with Foundation Medicine. And I'm with Foundation Medicine, and we work closely with lots of clinicians across the country doing comprehensive genomic profiling and trying to understand the genomic drivers of cancer. So I'm one of the local representatives in the area. So part of this program, and we have a close relationship with the Bonnie and Arios Association. So very glad to be here.
Thank you.
I'm Dawn Reagan. I'm with one of the drug companies that has four drugs for one learn.
Thank you.
Hi, I'm Karen Hosey with Genentech. We have a suite of drugs that are used in lung cancer, so here to learn. Thank you.
Well,
And we have a bunch of people online.
okay, you do. Wonderful. Well, the point of this meeting is to really address questions that the audience wants to hear and educate in areas that would be helpful to people who have the questions. We work with cancer every single day, and the questions and the thoughts that we have might not necessarily be the same questions that people in the audience might have. Maybe we could start. Mr. Brinkman, if you'd have any questions that you'd like to answer, and then I don't know if we should move along with our selected program, or maybe answer a few questions in the audience from the audience online to see if that might direct how we would move our thoughts.
Well, my question is, it seems like all cancer, and even lung cancer, is very genetic specific. So how do you, as it advances, what do you look for and how do you treat it genetically? It just seems like whenever I read it, people have different, just subtle differences of lung cancer, and so each patient gets their own treatment.
KARTIK, if I could add one little thing to that, and I'll have you, our expert, discuss this area. Everyone's talking about genetics and targeted therapy. What does that mean? What does genetic testing mean? What does that mean? Do we have what does it mean we have a mutation? I'm mutated, he's mutated. What does that mean? And maybe just
start from the beginning and give us some basics on that.
Sure. So, Mr. Brinkman, your question is very valid, and particularly for thoracic oncology, it is even more so. And I'll try, as we go through this program today, we'll sort of have a little bit of discussion about that. But as Dr. Mason was asking, of course, all our cells have nucleus, and in the nucleus there is a DNA. The DNA is the building block of our genetic material. All of us have DNA, lots of it, and the distinction is that there is a normal set of DNA. There is not a normal set necessarily, but a sort of a level of normalcy is maintained, and the body does its level best to maintain that normalcy for different people. When you have DNA, it builds proteins, and it builds molecular structures and helps regulate cell growth and cell death. And normal cell growth and cell death pattern is what we all have. Sometimes where that pattern is lost because of some changes, subtle changes in the DNA of tumor cells, that's when cancers are born. When that happens, we sometimes have the good fortune to be able to pinpoint where that change might have occurred, and then try to introduce some treatments against that particular change. Now, it's not necessary that only one change might occur, but in many lung cancers, for example, small cell lung cancer, even in non-small cell lung cancer, there's a lot of genetic variation that occurs, and a lot of mutations may occur at the same time. Not all might be affecting growth or change. Some of them might be, and some of them might not. What has become particularly more interesting in the recent past is that we have been able to identify certain subsets of the lung cancers that you talk about, where there is maybe one change, one DNA, one change in a particular level of DNA. Such mutations or changes or things where the DNA is not just only mutated, which means a certain building block is replaced by another, and there's a change, or sometimes a piece of that DNA is broken off and goes and joins with another piece somewhere. These are called gene rearrangements. Sometimes where there's excess of a certain gene that is expressed, which is called amplification. These things can sometimes lead to cancer. When such a thing happens, we call them driver mutations or rearrangements, which we can then focus on. We found in the last 20 years, 15 to 20 years, that particularly in lung cancer, there has been a big drive of finding these mutations in the DNA of our patients. And it started anecdotally, then it became something that we started seeing patients who had never smoked and had lung cancer. People started testing their genes and their DNA and found these things. That search continues to go along, and while that is going along, we have been able to, with the help of various clinical trials and innovative drugs, been able to find particular targets on those genes by particular drugs that might help reduce the burden of the tumor and therefore have an impact on the patient's life.
So let me ask you from a practical perspective, okay, Mr. Brinkman comes in, he's got lung cancer. You do a biopsy or you take it out and you find out he has a mutation. How do you find that out? What do you do with that information? Sure. Practically, what do you do with that information?
So, you know, we want the tissue. Now, there is some other stuff we will be talking about new technology. The tumor itself, right? Of the tumor itself.
The mutation is in the tumor itself, not necessarily in him in general.
Right.
And not in his skin, but in the tumor
Correct.
itself.
So, there are certain places where the tumor will go, and wherever the tumor will be might be accessible for a biopsy. You can access that tissue. When you remove that tissue, which is the tumor, the cancerous part of the cells, you can test them. There is a new technology where you can test these cells potentially floating in the blood or their DNA. When the cells die, they release and shed DNA, and you can pick them up in the blood. That's another new modality of testing. But the time-tested and true way of doing it for a long period of time has been do a biopsy, our surgical colleagues or our radiology colleagues help us get that piece of tissue. Then the pathologists access that tissue and send it to special labs where they can extract the DNA and test by various means, by specific tests, either by polymerase chain reactions or by next generation sequencing, etc. There are complicated tests that you can tell going through the building block of that DNA what the sequence is and whether a particular mutation that you expect to see or could see is there or not. And if that were to be there, the test will come out to be positive. That will be issued as a report.
So is that a good thing? Mutation or not a mutation? Do you want to have a mutation?
Some mutations are good to have, not that anything is good in lung cancer. We would rather that we don't see a patient with lung cancer. But in the general scheme of things, for patients who have lung cancer, there are some mutations which are very actionable. The word we use many times is actionable, and that means we have a target to use, to act upon, and that helps reduce the burden of the tumor. And then there are unfortunately some mutations which are not actionable, and they're present. Some of them are very commonly present, and when they are present, as of yet, at this point of time, we don't have good drugs or good treatments against them.
So by just stepping back a little bit, in terms of when you say actionable, and we say, the practical, what's the practical layperson, I got lung cancer, take-home message? You do a test, you find a mutation, and the advantage of finding the mutation is finding a specific treatment.
Right.
Right? There might be a specific medication, that's what we're talking
Correct.
about, that will act to kill cells via this mutation.
Right.
See, mutation, we have a medicine that works for that.
Right.
And use treatment against that mutation.
That's correct. That's
Okay.
absolutely correct.
Okay.
So that mutation is what is driving the cells. As I said, driver mutations. When these cells start growing, many of them will carry these mutations. I'm using the word mutation a little loosely. As I said, there are some other things like gene rearrangements, amplifications, etc., which can happen, but we're putting them all in one bunch. When you find these particular drivers, as Dr. Mason was talking about, you have particular drugs that can hone in on these changes in the DNA, so as to speak, and with that help shut down those tumor cells from growing any further and leading them to die off. And therefore the tumor burden reduces, the patient's life improves, the quality of life improves, and the quantity of life improves. And that's what we are trying to do with these drugs.
Right. If you have a mutation, patient has a mutation, does that mean I'm going to hand this off to my children? Does that mean that my children are going to get lung cancer? Does that mean that?
It's a great question. So there are some things called somatic mutations and there are something called germline mutations. It's a distinction that one needs to be aware of. Now Bonnie Adario's group is involved very heavily into looking at young lung tumor projects, and we'll talk about that in a second. But essentially, most of the mutations are not something that you pass along down the line in the generations. These are somatic mutations that occur, be it from some environmental influence or some other causation that we, as of yet, do not fully have an understanding of. But when that does happen, it does not mean that it will traverse itself down the line in through the generations. There are, however, some families or some groups and clusters of families who have been noted to have lung cancer. There are studies and projects in place where they are looking at these patients where these familial clusters have occurred. Now one could say, hey, maybe there's a lot of smoke or some other chemical that caused this to happen. But when they did these association studies, they found that they could remove the influence of those cigarette smoking and all that and yet see some familial clusters. So a genetic link is proposed in small proportion of patients with lung cancer that is still under study. We do not know the answers.
Do you think it's fair to say, just because I think a lot of people worry, anytime someone gets sick and they have family and they have children, and as a father, I always think that you worry about your children. So when someone gets lung cancer, I don't want to put words in your mouth. Do you think it's fair to say, for the most part, you're not handing that off, mutation or no mutation, to your family?
I think that's fair to say.
Okay.
Yeah. I mean, I don't think it's something that, majority of the lung cancers as of yet are still related to secondary causes like cigarette smoking and other chemical exposures. For sure, that is the main cause, and therefore it's not a genetic thing that you transfer. But even as you spoke about, David, those particular single driver mutations, we do not have any data to suggest that they move downwards.
Maybe tell me a little bit about, since we talked a little bit about medications for patients who have mutations of their tumors. Are these nice medicines to take? I'm leading you a little bit because in general there's some advantage to having this, because they seem to be medicines not like, tell me about regular chemotherapy and tell me perhaps about some of these mutation people and alternative chemotherapies that might be a little bit more pleasant to take.
Sure. So we'll start talking about chemotherapy per se. Chemotherapy was the main way of doing treatments for cancer care for the last 40, 50, 60 years. That's not changed. It still remains a very big proportion of patients being treated in oncology, no matter whether it is lung cancer or otherwise. We now have new therapies that have come up. But chemotherapy essentially involves drugs, chemical drugs, which target the DNA sometimes, and sometimes other apparatus in the tumor cell where there is growth happening. They could be targeting themselves to a different part of the cell and trying to destroy these cells when they're given. Most of the times they are intravenous in nature. They're given every so often, but unfortunately
how often do you get it?
So on an average it's every 3 weeks, but not all chemotherapies are alike, and some will be different. There are some oral chemotherapies, not necessarily in lung cancer per se, but in oncology, where you take a pill on a daily basis. That is still chemotherapy, but still it's a chemotherapeutic drug. So it goes in, it gets absorbed, and does something similar to what an IV drug would do. But in essence, these drugs don't necessarily target themselves to only cancer cells, and they unfortunately have many side effects, as you all know, and people understand the community circumstance of what cancer treatment is, and the first thoughts that come to mind are nausea and hair loss and fatigue and drop in blood counts.
Why do people lose their hair?
So
people don't like to lose their hair. That seems like the one thing that seems to happen a lot.
Absolutely. So it does happen wherever there is metabolically active growth of cells, like in the mouth, in the bowel tract, in the hair follicles, in the areas of the blood cells where the bone marrow is proliferating. All these cells are vulnerable to attack from chemotherapy because chemotherapy not just necessarily only hits the cancer cells, but hits these cells too, which are growing and rapidly proliferating. So, our skin cells, etc., they're all actively multiplying and dying, and multiplying and dying. So in some circumstances where you have a hit on some of these cells, you get these side effects. There are some other circumstances, like there are areas in the brain which control nausea, and some of these chemo drugs get in there, and there's some, like the chemoreceptor trigger zone in the brain, where if it impacts that, people get nauseated. But essentially, these are what chemotherapy drugs do. They have side effects, but they also, of course, have efficacy against the cancer cells, because these cancer cells are rapidly proliferating and dividing. And because they are, these drugs have the ability to come in and hit them and kill them off as well. The intention is, of course, that we kill more of the cancer cells off rather than the normal cells. But there's a trade-off, and we are willing to take that trade-off in majority of these circumstances, because if you can kill down the cancer cells and yet get away with somewhat of a minor side effect, and I use the word minor not lightly, I understand that for patients, as David is saying, hair loss, etc., is big. But when we are dealing with cancer care, we want to try to get rid of the cancer as best as we can. And so sometimes we are willing to take the other side of the story, which is the side effects and the risks. But when they do happen, this is what you see. So that's conventional chemotherapy, which has been going on in lung cancer and all other cancers for many, many years. They have become a little better in terms of newer drugs, and approaches have sort of varied to try to use them in the best possible way to reduce the most side effects and yet have the maximum efficacy. There are many drugs which we use. Some of them have been in play for a long period of time, and some have come up recently in the last 15, 20 years. And now what we are trying to do is use these chemotherapy drugs sometimes in combinations with other therapies, or in lieu of chemotherapy, we want to try to use other drugs like immunotherapy or targeted therapy that we talked about.
Kartik, I'm going to interrupt you.
Sure.
Do we have some questions?
We do have a question.
All right.
So I have a couple questions. So
Just scream, interrupt at any time. Feel free, seriously. Just raise your, don't, I'm sorry.
Where's my hand?
Yes.
So when we talk about targeted therapies, so a couple of questions. So how many mutations have specific targeted therapies for them? And then what kind of lung cancer patient gets tested for these mutations?
Great questions. Should we take them right now and discuss them?
Let's do
through
it. Let's do,
okay.
let's do the questions. We want the audience to
And then I'll
feel
have one more.
like they're getting their
Let's
questions
answer
answered.
two
So we'll try to keep. We'll try to move. How many
Right.
questions do we have sitting back there? You think? Just a couple.
Just
Okay.
one more after, and this is all about targeted therapies.
Okay.
Sure.
So
Sounds good.
We're on the same topic.
Sounds good. Okay. So we're back to discussing targeted therapies for a second. As we talked about, targeted therapies essentially have developed up until now mostly in non-small cell lung cancer patients, and mostly in what we consider or call as non-squamous cell non-small cell lung cancer. And the reason is varied. We haven't really found very good targets to be seen in small cell, and we can talk a little more about that. There's a recent development of some thought process about certain things like DLL3, etc. We'll talk about that. But mostly, coming to the crux of the question, this is non-small cell lung cancer, non-squamous type of non-small cell lung cancer, mostly seen in adenocarcinoma type of non-small cell lung cancer, and sometimes seen in large cells and such varied types of non-small cell.
Kartik, for the person who doesn't deal with lung cancer every day, what does that mean?
Good question.
What is non-small cell
So
lung
let's
cancer?
back up a little bit. Lung cancer is broken up in terms of non-small cell lung cancer and small cell lung cancer as the two major types. There are other small things, small types of malignancies like neuroendocrine carcinomas with carcinoids, thymic cancers, not exactly part of the lung, mesothelioma, which is part of the tumor coming from the lining of the lung in the pleural lining. These are the majority of the cancers. Non-small cell lung cancer contributes to probably 80% roughly.
Let me interrupt you again. So that's how it looks. It's non-small cell by how it looks under the microscope.
Right.
That's how you determine it. You
correct.
look at it and you make that determination by a
Correct.
biopsy and how it looks under the microscope.
Correct. So this is a pathologic diagnosis. This is not something I or David or anyone can tell you when you look at a patient. You may have some suspicions because there are some clinical characteristics of how a small cell cancer might present versus a non-small cell. But the answer is exactly right, as you say, David. You have to take a piece of tissue and send it out for testing. Send it to your pathology colleagues. They have to do put some stains on the tissue and look at it. And when they look, small cell lung cancers are essentially, in best way to say it is, they are small cells. They are small cells and they are all cohesively clustered together, and they look different than non-small cells. In non-small cell lung cancer, there are a few subdivisions. The largest of these subdivisions is adenocarcinoma. The second largest is squamous cell cancers. And again, these are how they look when the pathologist looks at them in the microscope. What that means is, do they form glands? Special ways of how they branch. Do they have a particular look or keratinizing look which makes them look like squamous cells? So there's different ways of looking at it. The pathologist tells us, hey, this is a non-small cell, this is an adenocarcinoma subtype, etc. And that's how we will know as to what type of lung cancer it is. Once we get that piece, most of the times when you do the testing, it's in the non-squamous, non-small cell lung cancers when we find these targeted mutations. Coming back to that. So what are the particular mutations that we test for? Well, we used to have a pie chart, and we still do, where the pie in the circle, we barely knew a little bit of the information 10 years ago. And every year upon year upon year, we keep finding newer targets or newer things that we can use to focus our results upon to try to find these mutations. So the largest of the mutations are called KRAS mutations. And I was mentioning before that KRAS mutations are unfortunate. There are some mutations where we do not have good treatments in terms of molecular therapies, and KRAS mutations are some of them. There's a lot of biological stuff regarding why that is the case, but needless to say, there isn't a targeted drug that has been yet developed or any other specific treatment that goes and attacks these mutations. It's not there yet. Hopefully we will have it sometime. Next to it, the largest set of mutations that we see is EGFR mutations. And EGFR stands for epidermal growth factor receptor, a particular gene which is sitting on a particular section of the DNA where there is a change in the mutation in a certain segment. These segments can be what we call as exons, and when you look at it, you can tell. Now, even there, not all mutations of EGFR are exactly alike, and some have a tendency to be very much affected by these pills and some not. EGFR contributes to probably, loosely speaking, 20 to 25%, 20% to 25% of lung cancers that are seen with these mutations. That's not all, but of those that you will see. A small proportion, a much smaller proportion of the pie is ALK gene rearrangements. ALK stands for anaplastic lymphoma kinase gene. A section of this gene goes and joins to another section of another gene, and it's called EML-ALK, and then they join together, and this thing drives the cancer. That's about 2 to 4%, roughly, I should say 4 to 5% probably. There's many more down the line that includes ROS1 gene rearrangements. ROS1 is probably seen in 1 to 2%. NTRK fusions are noted in probably 1%. BRAF mutations in probably about 2%. HER2 mutations and HER2 amplifications in 1%. And there are smaller ones like MET exon 14 mutations, which are seen in probably 1%. PIK3 kinase mutations probably in, given different studies, between 2 to 5%, 2 to 4%. And by the way, PIK3 kinase mutations can also be sometimes seen in squamous cell lung cancers. We don't have very good drugs yet for PIK3, but there are trials in progress. So we look for these mutations because we have the chance for having the patient go for a clinical trial later on. So those are the various mutations that we look for to think about. And as I said, a few years ago, we had EGFR and ALK. Then we had EGFR, ALK, and ROS. Then we had EGFR, ALK, ROS, and BRAF. And so on and so forth. We have had an expansion of these drugs or these targets, and we have drugs against them which are efficacious. So that's sort of where we are.
So how is the test done? How do you do the test to see what kind of mutation you may have?
So as I mentioned, you can take the tumor tissue by biopsying it.
Yep.
And the biopsy is done by either asking our surgical colleagues to help us if it's very difficult to get to, or by a bronchoscopy where the pulmonologist goes in and takes a piece of tissue out from the tumor, or our radiology colleagues to a certain extent help us by putting a biopsy through a transthoracic needle biopsy. That's sometimes if it's in the lung, sometimes it may be elsewhere. like in the adrenal gland, it may be under the skin, it may be in some lymph nodes, maybe in the liver, maybe in the in other parts of the body. And we want to get a piece of that tissue. Now that tissue is sent off in a formalin bottle or whatever to our pathologists. They do what is called fixation and preparation of that tumor, make some small cuts, slides, they put them up, and then they stain them, and you look at them, and that's how you tell what type of tumor it is. Well, then after that, some of these tumors are put in paraffin blocks, and these blocks are then sent off to specialized labs, where they can then do some specific tests, specific preparation of the tumor cells, and enhance the extraction of the DNA that I'm just was talking about, and use that extracted DNA to either amplify it and then put it through special testing mechanisms where you can go through the DNA coding of that tumor and look for certain particular areas. Even the tumor has a normal, it has the DNA that we would expect it to have, except there will be problems in some particular areas in that DNA. So you know how it would look or should look, and then here you come up with a abnormal signal. There are different ways to test for them. Next generation sequencing is one of them, and polymerase chain reactions for enhancing the amount of DNA and testing it is another one. Fish testing for evaluation for particular things like ALK, ROS, etc. we talked about. That's how fish testing is done. In this particular mechanism, a particular probe is sent in, and it sort of highlights and signals under a fluorescent microscope where the pathologist can read how many signals of that abnormal genetic gene rearrangement is present. And when you use that test, they count it, they tell us the number, they then tell us if it's positive or if it's negative. So there's various ways of doing it, but that's a very technical thing. And by the way, it takes sometimes a few weeks. Hopefully science and our abilities in laboratory medicine will allow this to keep cutting down, but it is one of our, when we are in conference, many of us are groaning about the fact that it takes a few weeks. Unfortunately, that's the limitation of our technology right now, but since it is that, we try our level best to do whatever we can to try to get our patient ready for treatment while we wait for these results to come back, and that's where we are.
And then what about doing, if somebody's progressed, what about doing
rebiopsy?
Rebiopsy, and who gets that? Who's eligible for that? Who does that? Are you using the same tissue, different tissue? How does that all work?
Sure. Before we get to that, I forgot to talk about the other modality of testing that has come into play, as I talked about, which is blood testing. There was something about urine testing too, but it's no longer being done by, there was one company doing it. I don't know if it's still being offered by others, I can't tell. But what happens is when these cells die, they shed their DNA into the bloodstream. And because of our advancements in technology, we are able to pick up these pieces of DNA, these fragments of DNA in the bloodstream of a person. The advantage being that if you take off a little bit of blood and send it off for testing, it's so much more efficacious, so much less invasive for the patient, rather than having to ask one of our radiology colleagues to stick a needle in and do a biopsy. So there is a technology, it's next generation sequencing and blood. They are able to cull out the DNA and then test it. It's still, in my opinion, a work in progress. What I would say is that if the test comes back positive for a particular thing that you are looking for in the blood test, I think majority of us would accept that as a sound result and valid result. But if it comes back negative for any particular mutation or whatever, most of us probably would say we probably need to search more. We need to do another biopsy to try to get a piece of tissue. That's what we would do.
Right. Maybe we'll move on a little. We talked a lot about that in detail, and I think maybe we'd move on to another topic. Stacy, we haven't involved you at all. Maybe let's start from the very beginning. You know, someone goes to their doctor, they have a little ache or pain or a cough, and they get an X-ray, and on the X-ray there's a spot, and
someone says, well, you may have lung cancer, and they call you, and how do you get started? You know, tell me what you talk about with patients. How do you get started in terms of the workup? Where do things go, and what are the questions that a patient needs to ask as they embark upon an evaluation of what might be lung cancer? What do you tell them?
Sure. So, of course, anytime there's a suspicious finding or a diagnosis of cancer, we always want to talk with the patient and find out a little bit more about their symptoms and kind of tell us their story, what's been going on leading up to this finding or their diagnosis. And as navigators, we're specially trained to help patients become informed so that they know what they may be facing, and providing them with timely information and resources so that they can find those appropriate resources, and of course helping to ensure that they're getting to the right physician at the right time, knowing that there's a multidisciplinary care team, and we want to make sure that there's coordinated appointments that need to happen for that patient to kind of help get things moving along.
How do you decide who the right doctor is, or what the right first step it might be?
Sure, it's going to depend on the patient's diagnosis and where they're at and being worked up for that diagnosis. Some patients that we see may or may not have had pathology yet, so they may still need a biopsy. So we're going to refer those patients to a specialist that can obtain that biopsy. Sometimes, in this case for lung cancer, it would be a cardiothoracic or a thoracic specialist surgeon to be able to obtain that specimen. Sometimes pulmonologist would obtain that specimen. It just depends on the location and size of that specimen, and if it's easy to obtain a specimen. Sometimes those specimens are very tricky to get to, so we want to make sure that we get that patient to the right place. If there's already been a diagnosis of cancer, we want to know if there's been any additional imaging done that we can obtain to provide the physician with that information so they can review that and determine if we have any metastatic disease. Generally speaking, if there's metastatic disease, we want to involve a medical oncologist, possibly a surgeon and a radiation oncologist as well. So we work closely with each other to make sure that we are coordinating those appointments to get that patient to timely care so they can get early treatment. So.
Stacey, you navigate not only lung cancer, other cancers as well.
Correct.
You know, no one ever wants to get the diagnosis of cancer in general, but I think there's a particular fear of lung cancer. What's different about navigating a patient with lung cancer, perhaps, than navigating a patient with other cancers, breast cancer, for example? Sure.
Each patient is unique, so every case is different, and there's multiple factors that we assess and take into consideration as we're looking at patients. And for those that have lung cancer, we want to make sure that, again, that they're getting timely intervention, especially if they have a situation that is needing to be treated more urgently. Some patients have tumors that may be obstructing airways or close to obstructing airways, so we want to make sure that we're cognizant of any signs and symptoms that the patient is reporting, because as clinicians we're listening and we're kind of on the front lines, so we want to make sure that if the patient is describing some symptoms that may include shortness of breath or anything that may alert us to a need to get the patient in even more quickly, we want to make sure that we're talking with that care team to ensure that that patient's getting timely care.
Do we have any questions out there from people online?
We've got most of them answered right now.
Okay.
It's been out there, yeah.
Okay. Well, KARTIK, patient comes in, they have a needle biopsy diagnosis of lung cancer. Tell me how you decide how to treat that patient.
Yeah.
Tell me sort of globally, from the top down, how do you get started? How do you treat a patient with lung cancer?
And before I go forward, there was a question that needed to be answered about rebiopsying. We'll come to that. I promise we'll answer that.
Okay.
Okay, so as you all know, as Stacey's talked about, a patient has a spot in the lung, patient gets a diagnosis of lung cancer. Everything just starts with the consideration for what this patient has is the stage of the cancer, right? We talk about staging, we are all involved in it. We cannot do anything without our surgical and our other colleagues being part of that care team. That's why when I started the introductions, I said that we need to come in as one group and one team to come in to try to help our patients. Well, one of the first things that we talked about is all this molecular testing, but a big proportion of our patients, maybe not the majority, but a big proportion need surgery. And we ask our surgical colleagues to help, right? How do we know where we are? Well, we have various types of scans and various types of evaluations that we would do to decide what the stage of the patient is. How big is the tumor? Has it spread to any of the lymph nodes nearby? Or has it spread perhaps even further to other organs of the body?
Could you give us a synopsis? What are the stages of cancer?
Right.
You don't have to give the nitty-gritty details,
right.
But how many stages are there, and what makes one stage versus the other?
Right. So in oncology, everything is based upon what is called the TNM classification, which stands for tumors, nodal, and metastatic sizes / locations. There are, in general, 4 stages of lung cancer. Even small cell lung cancer and non-small cell lung cancer can be talked about in the same fashion, but the majority of the staging we are talking about will at least stick with non-small cell lung cancer. The early stages mean the cancer is localized to the lung, a mass in the lung, perhaps may have spread to the first level of lymph nodes. That makes it a stage 1 to a stage 2. And when it goes to even further, a second level of lymph nodes in the center of the chest, it becomes a stage 3. When it potentially crosses from all these places and may go to other organ systems, it becomes a stage 4. And that's how we sort of get an idea about where the patient stands. And then we need to formulate a plan of how we want to try to treat the patient. So
do you think it's fair to say that cancers are treated dependent upon their stage?
Absolutely.
Is that right?
Absolutely.
So we determine treatment based upon stage. And I think you suggested it, but I think just to review, the earliest stage, stage 1, means it's in one spot, and then as we get to stage 4, it means spread throughout the body, and then obviously we cure more patients
in the early stages.
In the early stages than we cure in the later stages.
Absolutely.
Can we cure everybody in any stage?
We hope and we pray that we could, but obviously as the spread of the stage occurs and we move forward into 4th stage disease, cure becomes a much more difficult thing to try to aim for, and our intention and goal for such patients is to try our level best to keep them as functional as possible for as long as possible, improving the quality and quantity of life. Now, having said that, there are some specific circumstances where things have changed, and our surgical colleagues come into play for that. There are circumstances when you may have stage 4 disease, but it is just localized to one area. And I'm sure, David, you can tell us more about those circumstances. And then with new drugs that are in play right now, we are seeing many people live much longer than where we had similar cases in the past. So we remain hopeful for even the stage 4 patients in the future. But as it stands right now, yeah, you're right.
So you want to get it caught early.
You want to get it caught early.
Like any cancer.
Absolutely.
How do we catch lung cancers early? And maybe you could tell a little bit, and then we can leave it on to Stacy, and maybe we could talk a little bit about screening for lung cancer. How do we catch lung cancers early?
So unfortunately, lung cancers are, by the time they're picked up, majority of them, about 75 to 80% of them, are late stage. And that's a reason for it is they are sort of quiet, they grow, and they grow fast. People don't have many symptoms in the beginning, and by the time they start having symptoms, unfortunately, it has already spread.
Let me interrupt you for a second. Mr. Brinkman, you had an early stage cancer.
Yes, sir.
How did they find that? What was your story?
Well, my story is in the winter of 2016, of all things, a flyer came from Baylor Hospital, and it said, do you match this criteria? And it kind of bounced around. In April, I went and actually saw my general practitioner, forgot about it, and in May I found it, called her. She set up an appointment, And I went in on a Wednesday, and on a Friday they were calling me and said that they had found something in my lung, and I needed to see the pulmonologist. I saw him the following Wednesday.
So you had a CAT scan?
Yes.
A CAT scan. Low-dose CT scan. Can you want to talk a little bit about low-dose CT scan and that program? Then we're not unique to it, but of screening for lung cancer, who can be in it, why should they be in it, and
Sure.
how it works?
Absolutely, and I recall your story. It was wonderful. Great story, and this is a great example of the importance of early detection and early screening. And it's great to hear that, not to be gender specific, but that we have a man that has gone through a screening program and taken it upon himself to have that screening done. We want to encourage everyone to have a screening, lung cancer screening done that has a smoking history, and that goes for any other screening as well, whether it's early detection for lung cancer or ovarian or breast. We want to make sure that patients are educated about screening programs and that early detection is paramount and key in perhaps obtaining a cure. So we do have a low-dose lung screening program here, and there are low-dose lung screening programs all over where you can go and have that lung screening performed. Insurance is paying for that if you meet criteria. If you don't meet criteria, you can still have the lung screening done at a low cost to you. So I strongly encourage that and recommend that patients be proactive in their own health care and be informed. So recognize any symptoms or changes in your body. You know it better than anybody, and be your own advocate and encourage your physician to try to help find or test to see what's going on or what could possibly be causing something new. So
just to review, in terms of screening for lung cancers, people have been trying for decades to find a way to find lung cancer before you have symptoms, because by the time you have symptoms, usually it's more advanced. So many tests, but the one that has been proven to be effective in saving lives is a low-dose CT scan. So you go into a CAT scan machine in about 2 minutes, right, roughly, you're in and out, there's no IV, there's no nothing, and it takes a bunch of pictures, and if you get a spot, it finds that spot, and that's what lung cancers look like in general, a spot. There are specific criteria in terms of having risk factors. It's only an effective test if we're testing the right people. You can't test, every single person walking down the street. If you're 20 years old and you get that test, you're unlikely to have something. As you get older, and if you have other risk factors, you're more likely for us to find something. So I think you had some risk factors for your age, and I don't know if you're a smoker or not smoker. You're a smoker, and is it KARTIK, what's his age? Or give us the criteria.
So I think it was based upon a large study called the National Lung Screening Trial, or the NLST, which was published many years ago. And then over a period of time, many of the large national guideline creating institutions followed it and seconded it. So the way the trial was set up was 55 to 75 years of age, although I believe, if I'm not wrong, Medicare allows it to 80 years of age. You may correct me if I'm wrong.
So if you're older and you're in that age group, that's a risk factor.
More than 30-pack year history of cigarette smoking.
So if you smoke for more than a certain amount.
And then, or if you have quit, it has to be in a certain period of time.
Right.
And those are the major set of group of requirements for a patient to fall into that screening program.
So if you fall into the category, much like if you're over 50, you get a colonoscopy?
Yes.
If you're over, you get a colonoscopy. If you're over 50, you get a PSA. If you're a certain age, I'm not familiar with this, you're going to get a mammography. If you fit into this criteria, you should get a low-dose CT scan.
Right.
Now, this test is imperfect in that there are many people. It makes it sound like there are only people getting lung cancer who have smoked, and there are many people. How many people, what percentage of people are lifetime non-smokers who never smoked?
So about the current estimates are in the United States approximately 30%, probably a little more around that period, or that number. As I said, the pie chart is not complete. As we find more, we might exceed, but 25 to 30%. perhaps
Right.
a little more than that, are non-smokers.
Right. So not everyone who gets lung cancer is a smoker. In fact, that number is increasing. We see more and more patients who never smoked. And even if you have lung cancer and you were a smoker, that doesn't mean you smoked and it gave you lung cancer. It just means you smoked and you got lung cancer. So they're not, you know, does it contribute? Yes. But I think, you know, this test, this low-dose CT scan, it's important if you fit into that group of having the risk, you should have it done. And it helps save people, and it gets paid for by insurance, and your primary care physician should be doing it. You walk into his office, and you can look those simple little criteria up yourself and say, hey, should I get a CAT scan? And he should order it, and it should be paid for, and that can help save your life. In the future, we hope to find better tests, because again, it excludes that large group of people who never smoked, and who aren't in that risk factor group, who still get lung cancer. So that's important to know.
Right, absolutely.
So I guess my question is about those people, that group of non-smokers that you're talking about. How about them getting a early diagnosis? I mean, how do we kind of, or is that just
right? Many studies underway. Blood tests looking for tumor markers. The idea of a PSA. Breath tests, nasal sense, many different tests. None proven yet to
But they're
work.
working on it now.
That's what everyone wants. Early detection, you know, as a surgeon, I love to see early stage cancers. We take them out and the majority of people get cured.
That is the best time we can cure them.
The majority of people get cured. So to me, the way to save more people is to find more early cancers. And everyone, I'm not the only person who believes this or knows that, and there are many people working on it but haven't come to that conclusion yet. The low-dose CT scan, which only came out a few years ago really in terms of the test to show that it worked, I mean, that was a breakthrough study, all these x-rays being performed to try to screen people for lung cancer, just plain old x-rays for years. Never helped.
Right.
Never helped. So people said, I didn't get my x-ray. Well, it's never been shown to help. In low dose, this is the first screening test for lung cancer that's ever been shown to work. So that's progress. We'll take any progress in lung cancer. And for many years, there wasn't much progress. And we have progress in screening, and we have progress in all the new treatments that you're talking about in terms of medications that we're able to use and treat people. And even people who, talk about rebiopsy, here's a question I have for you. So you get lung cancer, can it come back? You took it out. I'm a surgeon, I took it out. It's all gone. Can it come back?
Sure. Unfortunately, the answer to that is yes, it can.
So now am I going to die? Am I getting lung cancer and it came back? Am I going to die? How am I going to get treated?
Yeah. So, well, it depends upon, where it comes back, how much of it, how much is the volume or burden of disease that it has come back at? Is it just one spot that came back? Is there a lot of disease that has come back? So there's always these risks and considerations. We try our best to intervene. Surgeons do their job. We try to maybe sometimes give chemotherapy in addition. Sometimes the radiation doctors come into play, etc. But these cancers have a tendency to come back. And the higher the stage, the more the risk of them coming back. When they do come back, can it affect the quantity of life for a patient? Yes, absolutely it can. That's where we come in. How do we know that they're coming back? We regularly monitor people with scans and look at them and examine them for clinical symptoms or situations like someone suddenly starts losing weight or
Tell me specifically, what do you do? Mr. Brinkman's follow-up. You got it out, gone, now what?
So
how often do you see him? What do you do?
So again, it all depends upon what stage it was to begin with, but in a sense, in a loose summation, it would be that every few months we would repeat a CT scan, and that few months is sometimes 3 to 4 months, sometimes it's 4 to 6 months in the beginning, and then it slows down over a period of time, and as we go 2 to 3 years, then you cut back from maybe 3 to 4 months to 4 to 6 months, and then after that, maybe after 5 years, you got cut back to once a year. So generally, that's what we do for our patients in follow-up. Again, everybody slightly differently evaluated and tested based upon what treatment they got and how much the burden of the disease was in the beginning. But in a sense, this is how we would do it.
And how long do you see each other?
Well, patients with lung cancer should be followed by their oncologist forever. So, I think that applies to many of the patients. This is my perspective. Definitely until 5 years. After 5 years, one could make an argument, hey, can I not just see my primary care physician? You should certainly see your primary care physician, But I would recommend staying and following with their oncologist at least once a year.
The other thing is people who have lung cancers, they're more prone to get another lung cancer. So there's a difference between also what we call recurrence, which means the lung cancer came back, your original tumor came back, and we always like to, your best time to be cured is the first time. Right?
Yes.
And then if it does come back, we need to determine, or if there is something new, we need to determine, is this a recurrence of the old disease, or is this the beginning of
a new disease,
a new cancer?
Well, we've had so many patients who we've followed over a period of time, and a new spot comes up, and many times we find it to be a different cancer, not the same as it started in the first place. Sometimes we can't tell, but there are many circumstances where we can.
How should a patient, Stacy, determine where they're going to get treated? What are important things to a patient? How should they determine whether they be here sitting in Dallas, because they should all come to Baylor, of course, here in Dallas. Just joking. But assuming you're somewhere else in the country, how do you choose where you go? What are the things that you should be looking for in a provider, in their CV, in their experience, in their whatever, in terms of trying to determine if you're somewhere in California or somewhere in Boston or you're somewhere in Texas or you're somewhere in Chicago? How should you determine where you're going to get treated? What do you tell a patient, or what do you think you should say?
Well, of course, you know, patients live in all different states and areas, and of course, when you hear the word cancer, you want to have and see the best team that you can see. In my experience with talking with patients, a lot of patients want to, you know, have a care team that's multidisciplinary, that involves multiple physicians that are collaborative and communicate with each other, open channels, and that they have an experienced team that is going to be able to see them in a timely manner and to take care of them. Sometimes when patients move to treatment status, they want to have treatment perhaps closer to where they live, and there's also clinical trials that may or may not be available at some organizations that we may have here, or another institution in another area or state. That clinical trial may not be available here, but it may be available there. So patients may be looking at multiple things that best fit their needs. One of the things that I like about our center is that we have a lot of resources available to the patient, and it's all in one convenient location. And I think having all of those resources and that specialized team for that particular diagnosis, whether it's lung cancer or breast cancer, knowing the physician's bio, CV, understanding how many surgeries they've performed, what are the outcomes from those surgeries, what kind of research have they done, what is their center doing to promote research, and also looking at the oncology and radiation oncology team and how collaborative is that team. And I think the other important piece to that is most organizations now have a patient navigation or nurse navigation team, and I think that's a really important care team member, as they help to coordinate and kind of become a central point of contact to make sure that everything is moving along and that everyone is you know, being communicated with and presented accordingly. So there's a lot of great organizations and physicians and oncologists and surgeons across the world, and I think it's a personal choice of the patient. I think it's who the patient is comfortable with. I see a lot of patients that will have an opinion at another facility or even in another state, and they want to come here and have a second opinion. I think having a second opinion is great. If you're not comfortable with the physician that you've reached out to and that you've spoken with you need to be comfortable with your physician, because you're going to have a long-standing relationship with them. So I think that's really important. But overall, I think it's a personal choice, and just having that support close to home if you live far away, and those are just some things to think about.
I'll answer that question from the surgical side. I mean, Kartik, you can answer that from the medical oncology side. How do you choose an oncologist to treat your lung cancer? In surgery, I think the things that you want to look for are a person who's obviously experienced. And by experienced, I mean who really spends their time focused on the treatment of lung cancer, and not something that they do as a relatively part-time job.
Yeah.
And there are ways of asking that question to the surgeon, and they're not going to be offended by it, I don't think. The reason that's important is because, you know, each and every day there are new techniques that are coming up, and if you're not spending your time daily, like anything anyone does in life, if you don't focus and you don't practice and you don't stay up, you're not going to be at the top of your game or the top of, you know, you want someone who's at the top of their game, who's taking care of you. This is your life, this is your operation. So you want someone who's spending their time doing that, because things change very quickly in the field of oncology as well, and you need to be aware of those changes. You know, the medical literature is tremendous now. I mean, there's articles after articles being, you know, printed. So if you're trying to do everything, there's no way you can keep up on what's most important in lung cancer. Minimally invasive surgery. You know, in the old days, which wasn't that long ago, you get a big, ugly, painful incision between your ribs. It was usually very long, and your ribs get spread, and then they take out that piece of lung, and you know, you go home, and it would be a pretty long recovery. Nowadays, most surgery, and I think 90% of our lung cancer surgery done here last year, was done with a telescope. So you get small incisions and no rib spreading, and you typically go home faster. And they hurt still, you know, it's not pain-free surgery, it hurts, but at the same time the recovery is better. It's more suited to more patients who may have been a little bit more fragile, unable to tolerate that operation. So you need to make sure your surgeon knows how to do minimally invasive surgery, and not every surgeon is going to be able to do that. So a surgeon who focuses on lung cancer, spends their time with the newest techniques, and works not solo but alone. You can have the greatest surgeon in the world, and if he doesn't have a good team, he's going to stink. He's not going to have good outcomes. So that team is large. That team is the operative team. You want to ask about that team. The people, their anesthesiologists, the nurses, the ICU, the floor. That's very important. Outcomes are easy to look up nowadays. You can look them right up on the internet and find out how your surgeon or your medical center's outcomes are. You may want to do that and ask what the survival is. You know, a lobectomy, which is the most common lung cancer surgery, the removal of the lobe of the lung. The right lung has 3 divisions, 3 lobes. The left lung has 2 divisions, 2 lobes. And typically a cancer lives in 1 lobe, so that lobe comes out. The risk of dying from surgery for that should be less than 1%. Yeah. If your medical center is having people die at more than 1% per year, you shouldn't go to them. I don't care who's doing them. It's a team process, so I would look that up. And then who works with other team oncologists, radiation oncologists. Did you have a question you wanted to ask? Go ahead, shoot.
So how do you know the difference between a thoracic surgeon, a cardiothoracic surgeon, and a general surgeon?
Just look at them. The really handsome one and very athletic is the thoracic surgeon.
You get a Navigator.
You know, not everyone understands that distinction, and many people don't even like that distinction, quite honestly. I'll give you a very short snippet. When you go to be a chest surgeon, there's a process of training. You go to medical school, and then you go do general surgery training, 5 years of surgery, where you rotate through everything: neurosurgery, trauma surgery, belly surgery, chest surgery. And at the end of 5 years, you're a general surgeon, but you are not specifically certified to work within the chest. And then to go into surgery of the chest, you do 2 to 3 more years of training, and you become a quote-unquote cardiothoracic surgeon, meaning you can do anything in the chest. You can operate on the heart and do a bypass. You can do a lung operation. However, in the year 2017, the areas of cardiac surgery and thoracic surgery have become so subspecialized that even in the field of cardiothoracic surgery, there are now people who spend almost all their time doing heart surgery and almost all their time doing lung surgery. And the training can be a little different too, because my training, I did far more thoracic training than cardiac training. So, you know, I'm a thoracic surgeon. The distinction is often only clear if you ask, but it basically means that you do only, for the most part, surgery of not everything in the chest except the heart, and I also do lung transplant. General surgeons work essentially mostly in the abdomen, and it's really the sort of being phased out as general surgeons working within the chest. So.
And then how is it determined which patients receive post-op therapy?
KARTIK.
So after the surgeon has taken out the lobe or whatever it might be, at that same time the surgeon also takes out not just the lobe of the lung, but there are many lymph nodes that come with that swath of the lobe, and the tumor comes along with it, and of course that's how we stage. The definitive stage comes up, well, there's a section of there's an idea that we get before we start the surgery, or before we ask our colleagues to, hey, take a look for surgery, is by the basis of the scans. But the definitive way we know it is after our surgical colleagues have taken out the specimen, the pathologists have looked at it, and then they tell us, are the lymph nodes involved? What is the size of the tumor? What is the exact size of the tumor? And how many lymph nodes are involved, and at what section these lymph nodes are involved? And I will go on to say that our thoracic surgery colleagues, as Dr. Mason is talking about, there has been a big issue about talking about lymph node sampling and lymph node staging, and how many lymph nodes should be taken out, and at what levels should they be taken out. And in general, if I may speak so as for my surgical colleagues, the thoracic surgeons obviously have been trained for that kind of stuff. It's not just taking out 1 or 2 lymph nodes, because these colleagues of ours are fully trained in knowing exactly where to take out those lymph nodes, because it has been a stumbling block in the past for many a year that we would not have adequate lymph nodes sampled, or whatever it may be, for whatever circumstance the situation may be. And this is one of the places where we significantly value their contribution. Okay, so once that has been done and the stage of the tumor has been talked about, there are certain circumstances that we have studied in literature which are clear-cut. Any patients who have lymph node involvement essentially will get some form of chemotherapy in the post-operative session. Sometimes they might even get radiation therapy, depending upon whether they ended up with some lymph nodes in higher level stations. As I was talking about, it becomes stage 3. We may talk about it. It's a discussion to be had. And then sometimes the size of the tumor itself might make us think one way or the other. Or if the tumor was touching an organ like a rib cage, or if it was touching the heart lining or something like that, it would upstage the tumor, and even the tumor might be small in its own size, but because of its location or where it is going, that's where we come in, and generally we'll talk about giving additional chemotherapy.
So going off of that is actually another question, is how many lymph nodes should be removed in order to determine when it's enough?
You know, in general, lymph nodes, you get what you get. You know, when it's sort of one of those things that not every patient you find the same number of lymph nodes as another patient. There are, without getting too specific, there's 2 issues. One is there's the number of lymph nodes, and then there's 2, the location of lymph nodes. In general, lymph nodes that are out to the edge of the lung, that are close to a tumor that may be living out here, those lymph nodes which are closer are probably not as problematic for a patient as lymph nodes that are determined to have been found further away. So these lymph nodes are called what we call N1 lymph nodes, and the lymph nodes in the center of the chest are what we call N2 lymph nodes. And it's more of an issue, the location and the positivity of cancer in the lymph node stations in their location, than it is in the number of lymph nodes that are found in the specimen. There have been a lot of studies and a lot of discussions about, you know, how many must you have, how many is adequate. I think the answer to that is unclear. the number of lymph nodes found in a specimen counted by this pathologist at Baylor might be different than the one across the street, and neither of them's right. It's just a different number because they're not so obvious. So I would say it's more of the location and the act of looking for those lymph nodes as opposed to the total number that are found. One thing that got brought up about after surgery treatments, how do you know if you're a candidate for surgery? Who gets surgery for lung cancer? And there's really two determinations of who's a candidate for lung cancer surgery. One is your stage, okay? Cancer that has moved throughout the body. To take out a cancer in the lung that has moved and spread to the bone, there's no value to that because you're taking this out and there's cancer elsewhere. So in general, patients who are candidates for surgery are patients who have tumors that are localized to the chest, sometimes with some movement to lymph nodes, in which we treat with chemo and radiation and surgery, but for the most part it needs to be within the chest that we can get it all out. If you can't get it all out with surgery, in general there's no value to surgery. And then, so that's one determination, the stage determination, and then the second is what we call the physiologic evaluation. That is, are you well enough to have an operation? Age doesn't necessarily preclude you. There are 90-year-olds running around out there who are on the elliptical or doing the treadmill or golfing who can get an operation, and there are 50-year-olds who are huffing and puffing and can't get up a flight of stairs who aren't candidates for surgery. So we need to look at their lung function. How good is that? And we get tests for blowing in a machine and seeing how good your lung function is. We get stress tests to make sure your heart's in good shape and that type of thing. So there's the two determinations. One is your stage evaluation, which we use CAT scans and PET scans and biopsies, and your physiologic evaluation, i.e., are you well enough to have an operation?
And then what about surgery versus radiosurgery?
So radiosurgery, it's a name that doesn't really correlate to surgery, and that it's not physically removed. The reason why it gets the name radiosurgery is the idea that you're killing it all and doing it in a very precise manner. And everyone thinks surgeons are precise, which if you look at their handwriting, you'd say they're not precise. But in general, it means that you're doing something very precisely and killing things right there. Surgeons take it out right there. Radiation hopefully kills it right there. And the way you do that is with radiation, and none of us is radiation oncologists, but I think I can synopsize their treatments. And they have in the old days, you get a beam of radiation that came through and killed the cell from the front, and then it came from the side, and that's what you got. And the beam coming through would injure a lot of tissue as it went all the way through you, and would injure a lot going all the way through, and you get a lot of scatter, and that wasn't very precise, and you need to get a lot of therapy, a lot of days of treatment, 2 months probably, every day, go in and get radiated. Well, now there are computers and targets, and you got a computer that can move your radiation beam and come at this tumor from so many locations and with such precision that it can put a high dose of radiation in a very small area. Give it to you in 2, 3, 5 doses, you're done. And the results are pretty good. But they haven't put surgeons out of business yet, fortunately, because it's good, but there are limitations. Still, in this country, in the United States, I think it's fair to say, if you are well enough to have surgery and to have it removed, the results are probably still better than radiation. Is that fair, KARTIK?
Yeah, I think one of the biggest problems for radiosurgery is we don't know what the lymph nodes are. We don't know whether the margins have been cleared, etc. So essentially it has been done in patients who have medically inoperable circumstances. That's been the historical perspective of the last many years. Otherwise, we usually ask our surgical colleagues to.
So just in terms of what I was referring to, so you need to be well enough for surgery. So let's say you have a small localized tumor, you're just not well enough. And those are the people in general in this country that we offer this radiation, and it's very good. And before we didn't have really good treatments, but now you can really offer a good treatment to a patient and the real potential for cure with that treatment. I wouldn't recommend it for someone who's still, I'm not saying 10 years from now I might not recommend it, but right now I still wouldn't recommend it. In other countries, tumors behave amazingly, you wouldn't believe it, but cancers of the lung behave differently in the United States than they behave in Japan. something about the genetics of the disease and the curability of the disease and the way cancers come and go away. There are certain areas and parts of Europe where they have better results in curing patients with sort of less aggressive treatments than they do in the United States. It's something about the genetics of the population. But in this country still, I think it's fair to say surgery is still the best. Radiation is very good as well. And the side effects are essentially zero. Some sunburn or maybe a little bit of pain at the site, so it's very good. How are we doing for time?
40 minutes.
40 minutes more?
We have some more questions.
Okay, sure.
So what role does surgery, radiation, and medical oncology play together? So how is it that I know to go to my team of doctors, or do I just go to one, or how does that all work together?
It works starting from the Navigator, I guess. so that's
You need
one.
a Navigator.
Right. So, I mean,
Maybe talk to them a little bit about what a tumor board is. Maybe
Right.
tell them
Yeah.
about
so some circumstances will be that the patient will come to us sometimes because the referring doctor feels like, oh, there's a lung cancer and the patient needs to go. But then we will realize that, okay, you know, this patient actually needs to see someone other than me for the first evaluation and treatment, and that might be my surgical colleagues or whatever the circumstance might be. But as Dr. Mason was referring to, we have what is called a multidisciplinary tumor board, where multiple doctors of different specialties, Dr. Mason from surgery, for example, and other thoracic surgery colleagues, radiation colleagues, pulmonologists, pathologists, oncologists, medical oncologists will all be sitting together and discussing a case. And in then circumstances like that, where a patient may need surgery and we are not sure, such discussions and decisions will be had. Or it might be, hey, no, this patient doesn't need surgery, it should be handled by medical oncology. Well, then such circumstances will be discussed. Sometimes it's not even necessary to do that, and you know ahead of time, you know, I might get a call from Dr. Mason and say, hey, I have this patient, we were going to try to operate on this, but it turns out that at the time of surgery or even before, we found out that this patient is not a surgical candidate and therefore needs to come to one of you guys. So that's how it works. And then we sort of collaborate amongst ourselves and to formulate a singular plan.
Yeah, in general what will happen is, let's say I have a patient and they come to me and it looks like a cancer that should come out, and I'll operate on that patient, and 7 days later I have all the results from that operation. The tumor was so big, the lymph nodes were involved, and I bring that case to tumor board and I present it in a room of 20 people with pulmonologists and oncologists and pathologists who show the slides and look at it under the microscope and review all the imaging, and then we say, what should we do next on this patient? And then we make a consensus decision. That patient needs chemotherapy, and then the patient gets referred to the oncologist for treatment. So that's in general how it works. Each stage of cancer in general has a particular way of being treated. There is some variability, to it, but a stage 1 cancer for the most part gets surgery or radiation, that we're talking about that radiosurgery, in observation. Stage 2 cancer in general gets surgery with removal and likely chemotherapy after. Stage 3 cancer, that is a cancer that has cells that are in the center of the chest and lymph nodes in the center of the chest. There's some variability, but in general, if you're pretty fit, you'll get chemotherapy, radiation therapy, surgery to remove it, and then sometimes some more chemotherapy afterwards, but in general, observation. And then stage 4 cancers are usually treated with some form of chemotherapy, whether it be IV or with pills or something like that. So if there's chemo involved, there's an oncologist. If there's radiation involved, there's a radiation oncologist. And then if there's, you know, a surgeon on a stage 3, then there's 3 people involved. And we all try to follow the patients afterwards together, coordinate our office visits. If I'm seeing a patient on a Wednesday, you know, Dr. KONDURI will see that same patient on a Wednesday in his office, so we try not to make it too cumbersome for the patient to be seeing all these doctors, but it makes us feel good to see our patients over time.
And then the targeted therapies fall into that kind of decision making too.
So targeted therapies as of right now, as it stands currently, and that might change, are mostly meant for stage 4 patients. There are studies that are being done, not just with targeted therapies, but with immunotherapies as well, where patients after having surgically operated tumors and early stage cancers, or after chemotherapy and radiation for stage 3 cancers, could get on to having immunotherapy as afterwards, or targeted therapies in clinical trials. So that's still being studied and evaluated. That's still not considered standard of care, but that's part of trial-based evaluation.
What's a small cell cancer? Is it good to have a small cell cancer? Bad to have a small cell cancer? Does it make any difference? We didn't mention that at all. Tell me about that.
So small cell cancers are about 15 to 20% of the other group of the largest parts of lung cancer, and these are arising from different sets of cells, and when they are evaluated on the microscope, they have a certain look, and they stain with a different pattern of stains, and that's why the sort of common parlance term of small cell lung cancer came into being. But these tumors are aggressive. They start somewhere in the center of the chest, or sometimes on the sides or in the lungs, and then they can spread. And their treatments are typically evaluated in terms of limited stage, which means if the cancer is somewhat in the chest and it's localized to one particular area, where we can give a radiation to a certain section of that, covering that tumor along with chemotherapy. That's limited stage small cell lung cancer. Or if it has spread out, it's extensive stage. Now we, of course, David, you can talk about surgery, and very early stage small cell lung cancer, sometimes we can pick them up. Sometimes you would have done a screening evaluation and you find it. Sometimes it comes up when you don't expect it. You think it's a non-small cell lung cancer, but it's sometimes a small cell lung cancer. But it's early stage, it has not spread, and we will ask our surgical colleagues to come in and operate on it, especially if it's not involving the lymph nodes or hasn't grown too big a size, and then we'll come in and talk about doing chemotherapy. Then there's this whole concept about doing radiation to different parts, specifically the brain, for both small, limited stage and extensive stage small cell lung cancer, and that's how we essentially treat these people.
You mentioned spread to the brain. So someone comes in, they're having symptoms a little bit, something funny is going on neurologically, and they get an MRI. They have a lung nodule, and they have a brain metastasis. Metastasis is a spread. Am I incurable? It's a stage 4, right? Am I incurable, doc? Is there anything I can do? And are there other situations where we're talking about stage 4 cancers,
right.
Obviously?
This is one of those.
Is there any cure for patients with stage 4 lung cancer?
So there are these small group of patients that we see that we feel we should try to do as aggressive a pattern of care. They are stage 4. Let's clarify that. They are stage 4 lung cancers because they have spread out of the lung and have gone to other organs, like in the brain or in the adrenal gland or in the liver, sometimes in the bone. Particularly things like in the brain, etc., where there's one spot that is there in the brain, we hope that being more aggressive might yield a more fruitful outcome. We understand that these patients are at a higher risk of relapse than a regular stage 1 or a stage 2 cancer, but given the fact that there has...
What is fruitful? Fruitful is cure? Can we cure patients?
Yes, there is possibility of cure for some of these patients.
Right, because usually we don't talk about cure for stage 4, so
you're
possibility of cure.
Possibility of cure. The numbers are small, but it is certainly a possibility, and we want to afford that to all of our patients who can get that treatment. And then we ask for being as aggressive as we can and trying to involve neurosurgery sometimes, or radiation depending on the circumstance, along with chemotherapy, and then along with thoracic surgery to take out the primary tumor in the lung. There are some small circumstances. There are reports and pieces of data in the literature in lung cancer where such patients can get cured.
So just to go back, so just in terms of terminology, this would be considered oligometastatic disease. That means that you have a primary site of cancer and then either a solitary other site of cancer. And the brain is the most common site where we see this, the adrenal gland occasionally, rarely to the bone where this is an issue, where cancer is spread one site. And if you were in that situation and there's no talk or consideration about, treatment for cure, and typically that treatment will mean complete control of the brain lesion by either surgery or radiosurgery, and complete control of the lung lesion, typically with surgery. I mean, that should be, you should ask your doc, is that a possibility for me? Solitary site. Unfortunately, most of the time when lung cancer spreads, it doesn't land in one site, it lands in multiple sites. So in the occasion where it does happen, and it's a real number of patients,
yes.
It's not,
We've all seen
it's not like one in a gazillion, it's one in a real number. I don't know that number. But it happens, and you should be considered for that therapy because, for the most part, you want a cancer out if you were going to be considered for cure. So oligometastatic disease to the brain, occasionally we treat with surgery, radiation. Oligometastatic disease to the adrenal gland for one reason or another. I don't know the reason. It likes the adrenal gland. Lung cancer likes the adrenal gland. Lung cancer likes the liver. Lung cancer likes the bone.
Yeah.
And those are places it more commonly lands. And that's why we get, when we're evaluating patients in terms of their staging, we want to see if there's disease in those other sites. And that's what a PET scan in general tells us. A PET scan is a type of non-invasive study where you get a type of contrast injected into your vein and has a nuclear tracer in it. And the more active cells in your body pick up this tracer and glow on the pictures. So you go through a CAT scan machine and they glow. And because cancer cells are more active, they tend to pick up this tracer and glow. So we look for glow unexpectedly in other areas than just the site. So we expect the cancer to glow, but we don't want to see glow elsewhere in the body. So if there's something in the bone, in general, we're going to see it in the PET scan, and there's something in the adrenal gland, in general, we're going to see it in the PET scan. If there's something in the brain, we usually get an MRI because the PET scan is not great for the brain. And those are the studies that are in general are utilized for staging of lung cancer: PET scan, a CAT scan, and a brain scan to rule out disease spread.
So there's a lot of talk and a lot of news about immunotherapy. So can you explain kind of what that is and how that works and who's eligible for that kind of treatment?
Sure. Immunotherapy is a new form of treatment. We talked about targeted therapies, we talked about conventional chemotherapy, but immunotherapy has come to become a major player in anti-cancer treatments for many cancers, including melanoma and other malignancies, but particularly now we're talking about in lung cancer. There have been clinical trials that are done and are being done while we are talking about them at this point of time. They're not only being done for non-small cell but for small cell lung cancers, where we are trying to utilize our own immune system to try to fight these cancers by potentially removing the blocks that hinder the immune cells from recognizing the cancer cells and trying to come and fight them as best as we can. There are various types of immune therapies, and particularly the two big types of the classes of drugs called PD-L1 or PD-1 inhibitors is one class, and then the other class is CTLA-4 inhibitors, which sort of have taken the big lead as of right now in terms of treatment modalities. In lung cancer, in non-small cell lung cancer, immunotherapy is approved in the frontline setting if the tumor expresses a high proportion of a particular protein called PD-L1, and if there is a presence of more than 50% of the cells having it, immune therapy would be considered as a standard of care.
Let me just clarify, what is that, again, who's a candidate and what does that mean frontline?
So these would be stage 4 patients who are already have a diagnosis of lung cancer where the tissue has been evaluated. These are non-small cell lung cancer patients, and they don't have to be any particular subtype of non-small cell like squamous or adenocarcinomas. Both types can be potentially eligible, but these are patients who have stage 4 disease, who have been noted to have cancer in different places and have not yet been treated for their lung cancer as of right now. That's frontline, first-line therapy.
The idea is this is better than chemotherapy?
Yes, the data from a particular set of trial has shown that when compared to chemotherapy, these drugs did better for particularly this group of patients who have high expression of immune therapy markers. So it's a standard of care, it's an approved regimen by the FDA, and it's a treatment that one would use it's given IV, it's given every 3 weeks. That's for the frontline patients, that means who have not been treated. However, even for those patients who have been treated with chemotherapy, there are drugs, at least 3 of them are approved at this point of time, where there has been suggestion of benefit for patients who have failed frontline chemotherapy and have gone on to get it as second-line treatments. There are nuances of how you do the test and what drug you might choose, etc. But there is data to suggest that this also seems to do better than what would have been conventional second-line chemotherapy if the frontline chemotherapy failed. There is data now to suggest that for stage 3 patients with chemotherapy and radiation complete, for them to get immunotherapy of a particular type, stretching on for about 1 year, might help improve their chances of survival, at least to stay free of the disease, free of progression of the disease, I should say. Let me clarify to make sure. Free of progression of disease, also what we call as PFS, for these patients. It's not yet approved by the FDA, but has been shown to be beneficial, and many of the larger national guidelines have already started looking into it. We've used these in small cell lung cancer too. And there are studies that are ongoing as we speak right now, where immunotherapy is being used to try to enhance the kill on these small cell lung cancers in different settings. It could be in frontline setting where people have not had chemotherapy yet, but these are on clinical trials, or in the second and third line settings after failure of chemotherapy. Some of that has already been evaluated, but there's a lot more study yet to be done in that regard.
So do you think it?
And then how about side effects?
Yeah.
Of that versus, say, chemotherapy or...
Sure. So all drugs, whether they be targeted therapy, their immunotherapy or chemotherapy, all have some levels of side effects. The side effects vary and differ. In immunotherapy particularly, they're not the typical hair loss kind of scenarios. Most of the times when the immune system is revved to try to fight the cancer, it sometimes can also go and attack the skin and cause inflammation of the skin, like rashes. Can you attack the colon and cause inflammation of the colon and cause diarrhea? The liver can be inflamed and the liver enzymes can go up. The lungs can be inflamed and you can have shortness of breath and trouble breathing with that. It can affect the hormonal systems and have an impact on the thyroid gland or the pituitary gland.
Are these common side effects?
So these are, to some level, very low-grade side effects are not uncommon and may be seen in 10 to 15% of the population, but the high and more serious side effects or the high-grade side effects are much less common. We don't see that frequently, but we do see them. Again, it's not to say that they don't happen. And when we do see them, we try to treat them. We anticipate for them, we look for them, and if we find that they are to some level, we try to treat them with therapies, particularly steroids, to try to help improve the side effects.
So do you think it's fair to, yes?
Oh, no, go ahead, please.
Do you think it's fair to say then that there's still hope and there's more treatment for people who failed therapies?
Yes.
Now? Failed
Yes.
chemo?
Yes.
There's something else?
Yes.
It's not hopeless?
Yes, I mean we have seen a new vista of treatments open up because of immunotherapy, a new hope for our patients. Many patients who actually respond very well may stay responding for many years. I mean if they respond, their responses can be long-lasting. They can be deep. When I say deep, I mean by the tumor tissue can significantly get cleared up from the body, and they may go on for many, many years without having a relapse. We've seen that, and so there is definitely new promise.
My question was back to the screening that you were talking about earlier. get probably isn't covered by insurance. So is it the insurance that's the limiting factor for the risk factors, do you think, or that they don't want to pay because the risk for patients to get lung cancer or non-smokers is so much lower? Or is it also a concern, which is why the low-dose CT scans have come to the market because of the radiation exposure that you would get? Is that an issue that contributes, or is it really just about who pays?
No, it's not really who pays. It has, you know, I'm not an epidemiologist, and there's a lot of statistics that go into what makes an effective screening test. And there's the test itself and what you find, and then there's the test itself in terms of what you find and do with that information. And if you screen millions of people, just get a CAT scan on everyone, the radiation is relatively trivial. You know, so it's not really going to be that effective a test because you're finding a bunch of things. You know, what's the likelihood of you having a cancer in a 20-year-old person walking down the street who lives in farmland, who's exposed to fungus in the soil, and that likelihood of that lung nodule, which he very might have, a nodule is a spot, it's almost not, certainly not cancer, but now you've got a lung nodule that's been identified on a CAT scan, and that test, which was validated for this subset of patients as being effective and working in screening patients, if you include these other patient populations, is not going to be a valuable test. Does that make sense to you?
That makes sense. I guess I just, you know.
And then, you know, there are, you know, one of the statistics that they looked at in that the lung cancer screening trial was what are the downsides of screening, because that screening leads to potentially another CT scan or a biopsy through a needle or a bronchoscopy or even an operation. And some of those patients who got the biopsy got a complication. And some of those people who got an operation got a complication and died of that complication. And that death may have been from surgery to take something out that was not a cancer. So now you're going down, all those numbers need to be factored in to whether it is a good test.
You know, it reminds me a lot of the mammography story now, where there's just so much controversy over how quickly do you get them, and then our people end up with additional tests that are unwarranted because it turned out that it wasn't.
Right.
I guess, you know, for me, it seems like that epidemiology piece is more about kind of the masses, really, and yet there are patients within, you know, even that 30% of the non-smokers who probably might have been picked up and stuff. And so, you know, I just feel as a consumer of healthcare, as my family is, and, you know, I was thinking from the angle of a disabled child that I have, you know, how do you, as a consumer of healthcare, ensure that you're getting the best as a patient who's an N of one, you know, versus kind of the more mass thingy. And so for you folks, do you guys consider doing low-dose CT screening, you know, just to have the information and then kind of figure out what you do, you know, being in the inner knowledge kind of circle? Because I do feel like there is, at least in my daughter's disability, kind of a variable level of care depending on how aggressive you want to be in approaching the next sort of treatment for her. And I don't know if that is the same within lung cancer.
Yeah, I mean, there are executives out there, you know, who make a lot of money and go to their concierge doc. Nothing wrong with them, but, you know, they're going to get a head-to-toe CAT scan, okay? Now, is that cost-effective? No. You know, is that likely to find something? No. Might you find something? Yes. Is that something that I would recommend for everyone? No. And certainly, you know, if you want to step back and look at the cost of the healthcare system in general, it's absolutely not warranted. Would I get one for myself? No. No. I don't think the likelihood of finding something is very high, and it's just going to worry me, and maybe they're going to find something I'm going to be worried about. I don't do that. Do you want one, KARTIK?
Yeah, so I mean, I think that's a valid question because there's a big proportion of patients. But, you know, all tests are run, screening tests are particularly very prone to a lot of bias. And you have to be very careful about how you apply a screening test meant for a particular population now being generally used to for a bigger, wider proportion of people. And then there comes a lot of statistical problems with it. So that's why we have national guidelines. And I agree with Dr. Mason completely. I mean, we would probably not step out of those bounds, because if you increase the chances of a test showing a false positive or some other thing, then it comes out to be having procedures which then generally increase the risk of complications and not provide improvement. So all screening tests must improve. No, sorry, let me back up. In lung cancer cases, CT screening must show to improve lung cancer related mortality. That's what it must improve. The only piece of data so far that we have of an improvement, apart from smaller other trials in collaboration with it, the largest piece of data is from NLST. And the NLST trial did this particular. There have been studies which I don't know all the particular details about, where they have tested it for non-smokers, etc. And as you drop down in the quartiles or of risk of population, the likelihood you will catch these patients by doing this kind of a test is very low. So until new data comes out which shows, hey, maybe this particular population will benefit from a particular test, applying it generally dilutes the benefit of the test and increases the risk of complications.
That makes sense. Thank you.
Mm-hmm. Yeah?
Question. So today Genentech announced this combo, IO and Avastin and chemo. How might this change how IO is used?
So I don't know yet how IO is going to be used in different combinations in different ways. It has already been approved by the FDA for combination with chemotherapy. It has multiple clinical trials are being evaluated in different combinations and in sequences, or as I talked about, stage 3. I think it's a work in progress, and I do not know where things will go in terms of the long-term outlook for patients. I don't think there will be one particular answer that fits all. There will be differences in biases, and that may not be a bad thing. We will learn more as we go along down the line. But as it stands right now, until it shows a clear evidence of efficacy and improves overall survival, and the cost is always a factor, all those things will come into play as we combine these drugs, which are extremely expensive and also somewhat toxic to patients. So we want to try to be the best advocate for our patients, and that's somewhere we will find a way.
So just stepping back in terms of the things that we talked about, starting at screening. I think the things we've talked about is, if you fall into the risk factors for screening, there are many, ask your primary care physician. Mm-hmm. If you're an active smoker, or smoked for a while, and you're older than 55 years old, it's reasonable to get a CAT scan to be screened. It should be paid for by insurance. If, for one reason or another, you're not quite in that category, and you want a CAT scan, many places will have discounted prices, $100, $200 for a CAT scan that you can do. So from a screening perspective, that's what we have right now, and there are more tests underway. A lot more studies being done on what's good in terms of screening, but very important. Early detection, very important. We talked about lung cancer not being just a smoker's disease by any means. Many more young people getting lung cancer than ever before. Many more non-smokers getting lung cancer than ever before. Cannot gloss over the fact that smoking is a risk factor for cancer. Of all the things that you can do to lessen your chance of getting lung cancer if you're a smoker is to stop smoking. And Stacy, I'm sure you have ways to get people to the right people to help stop smoking, because it is very hard to stop smoking. I certainly never pass judgment on someone who's having trouble quitting smoking. It is tremendously difficult. Yes?
On that subject, now that e-cigarettes are so popular, especially in the younger population, have there been any studies and seen any correlation between that the e-cigarette?
You got a comment on that? I can make a comment. Or?
Is there any data on that? Because it's so prevalent, especially in the younger population.
The specific question you're asking is, has e-cigarette made a reduction in smoking-related cancers? Is that what you're asking?
Well, or is there a correlation between e-cigarette smoking and cancer?
So I think the answer to that is, okay, I don't know all of it, but I will explain to you the best I can. From what I understand, it's a little premature to tell exactly what is going to happen. It takes a long time before you can try to figure out cause and effect relationships between smoking and lung cancer or other diseases. And it takes a long time to clarify whether or not that makes a difference. I can tell you, however, that e-cigarettes, if you look at the American Cancer Society website, it will tell you that even these have risk of problems with it, including with lung cancer, etc., because it's not just the nicotine, but it's the solvents and the other stuff that is in the e-cigarette that may be an issue. I don't know that quitting completely is completely the right thing to do, as best as quickest as possible. I don't know that there are any comparative studies that I can tell you that will tell at this point of time. In e-cigarettes is what, a few years old. It took us like 30-40 years to try to figure out how much the connection is. Obviously, one hopes that it is less, but is it a gateway to another significant level of smoking or some other utilization? That's another concern. But I will tell you that there is this issue of concern.
Yeah, I mean, on e-cigarettes, I think there's a lot of data emerging. One thing is not every e-cigarette is created equal. They're poorly regulated, and there's a lot more regulation coming down the road. And anecdotally, talking to patients, some patients say e-cigarettes are helpful in getting them to cut down from smoking regular cigarettes, but I think the data does not support that as a smoking cessation tool. Is it better to have an e-cigarette than a regular cigarette? And the answer, I think, will almost certainly be yes. Better to have, and there is formaldehyde in it. I think there's a lot of concern with that, but I think the answer is, well, it's not good to have those either. It's probably better than that to have a regular cigarette. Will it prove to be a smoking cessation tool in the future? I don't know. I don't think so. Will the prevalence of that lead more people to convert from e-cigarettes to regular cigarettes later? A lot of people trying to figure that out. So I don't know. I don't look down on people who come to my office and say I switch from one to the other. If they're not smoking regular cigarettes, I'd rather see that, honestly. I'd rather see them smoking nothing. There are better tools than that in terms of stopping smoking than that, but it's something very important to try. People who've had lung cancer and persistent smoking are more likely to get cancers, and their prognosis is worse.
And new lung cancers and
the prognosis is worse independently if you continue to smoke after lung cancer. And just to show you the power of the addiction of lung cancer, you would think if there's one thing that's going to make you stop smoking, it's getting lung cancer. But many people smoke after getting lung cancer. It's just very hard to stop. So
agree, completely agree.
But try to stop smoking, get treated by a good team, whoever that team might be. Make sure your team is experienced. Make sure your team is collaborative. No man is an island or no woman is an island. You cannot treat cancer well by yourself. Stages of cancer determine treatment of cancer. Even stage 4 cancers, if you're not curable, which there are some people who are curable, your life can be extended a long time.
Yes.
And no one can tell you how long that time is, so we don't want to give up on patients at all. And there are patients, my gosh, I'd see them and I thought they'd be gone long time ago, and they're doing great. No evidence of disease. Is the cancer gone for good? No. Is it not visualizable now? Yes. And they're living just fine with that. So never give up hope in this disease. Terrifying diagnosis to get. Probably of all the cancer diagnoses to get, it's going to be one of the most terrifying to get. But there's a lot of support out there. The Adara Lung Cancer Foundation does a great job of supporting people in many ways, and events like this, I think it's wonderful. Thank you.
Well, and on that note, I'm going to say thank you, Dr. Mason and Konduri and STACY. This was amazing, and everyone online has this. They just love it. This is everything they needed to know, and then some.
Well, one thing, if I may, someone asked that question, I did not complete it, about the rebiopsy. Let me just close that part. Suddenly remembered, yes, we will rebiopsy people who have molecular markers or DNA changes. If they fail that drug that they are being treated for, many of the times we will rebiopsy. But that's not applicable for all. Just be aware of that. So just putting it out there. Thank you for having us.
All right.
So thank you everyone here and online. Thank you to DJ's Catering for the food, and thank you to Beverly Boy, and I'd like to thank Astellas, Bristol Myers Squibb, Celgene, Genentech, Lilly, Merck, Novartis, Tesaro, and Yahoo Employee Foundation for all their support so we can bring this program to everyone. So thank you.
Thank you.
Thank you.
Thanks, boss.
Yeah, thanks. Great job, Kartik. Stacy, thank you.
Thank you. Hey,
Thank you.
good job.
Thanks for being
Learned
here.
a lot.
Appreciate
Good
it.
stuff. Learned stuff I didn't
Mr.
know.
Brinkman. Yes, sir. Take care, sir.
Thank you so much for being here.
Thank you.
Thank
Good
you so
stuff.
much for supporting us and
I got to get
all the other
booked.
people who get
Okay,
inspired.
good stuff.
Wonderful.
Take the one we
Oh,
have.
oh, yeah. Okay, are you sure?
Talks about that. It's amazing.
That's even better.
But you did the right
Sure.
And then we'll send you.
Dr. K.
Good to see you.
Nice to see you.
Good to see
A
you.
pleasure.
Thank you.
You're welcome.
Well, I don't know.
All right, very good. See you.